All right, we're live. Hi, everyone.
Hello, fantastic. Maybe give it another about 20 people in the waiting room. Marina, you tell me when you want me to go.
We're
I take
ready.
my
We're live. And no one's in the waiting room. Everyone's in here watching.
fantastic. All right. Hello, everybody. For those of you who don't know me, I am Allison Agu. I'm a professor of adult and peds ID here at Hopkins. But today I wear the hat as the JH Wiki, or Johns Hopkins Women, Infant, Children, and Youth Partnership for Excellence in HIV Care across Central Maryland. Before I go even further, I would be remiss if I didn't welcome back my partner in crime, Marina Stenoforte, who's been out on medical leave, and I'm just so excited to have her back in my back corner and with her hat on my back. So welcome back, Marinas.
Thank you.
For those of you who don't know about the JH Wiki partnership, really it's a multi-site initiative, which I'm truly blessed to lead, with the vision of achieving a more coordinated response to HIV care by establishing mutually beneficial relationships that increase the quality of care that we provide as a community to the Wiki population. Our mission is to build upon existing structures and systems, not recreating the wheel, but creating a dedicated network of Wiki providers to coordinate across multidisciplinary systems of care. Our Part D network toolkit series really excites us because the goal of it is to engage and amplify. And what we mean by that is not having the same old topics to the same old people, but really to look to experts all around us in our region to engage and amplify them. So you'll hear us say multiple times, if you too have something that you think would be great to share, please let us know. We'd love to share and have you engage and amplify. Next slide, Marinas. Today, we're excited to have Matt Grant with us. We'll talk about that shortly. But when you look, and we have a bank of our talks, Caring for Immigrant Populations with Kathleen Page was in February, Optimizing Provider Pharmacist Connection. And next month, we have a youth roundtable, which promises to be amazing, and then the list of topics moving forward. But first, the next slide. It is my extreme pleasure to introduce Matt Grant today. Matt is really excited about having more and more people join us today. Matt is an assistant professor of pediatrics at the University of Maryland. He completed medical school at the University of Maryland School of Medicine, my alma mater, and his residency in peds at the University of Maryland Medical Center, and served as the head honcho, the chief resident at that time. He serves as the medical director for the Adolescent and Young Adult Center within the Division of Community Pediatrics and Adolescent Medicine, providing primary care and HIV medical care. Today, he's going to talk to us about something he has really not just talked, but walked the walk as well, engaging and retaining youth in care, creating alternate spaces and places. Matt, unmute and take it away.
Thanks so much. All right, I'm going to get my slides up. And I almost inevitably always put them on the wrong way, so just let me know when they're right.
They're not in presenter mode yet, Matt?
Yep. All right, they're the right spot.
Perfect.
Okay. So as Allison said, I'm going to talk about engaging and retaining youth in care, creating alternative and spaces and places. So I have, unfortunately, no financial disclosures to but if you have any for me, I'm happy to take them. So today we'll talk about we'll identify some missed opportunities for engaging adolescents. We'll examine some factors complicating adherence in adolescents and young adults. And we'll discuss some strategies to overcome those barriers associated with poor adherence and retention to care in adolescents. So I want to start with the HIV continuum. This is probably familiar to almost everybody on the call. This is from 2019 in the state of Maryland. And I like this one because it's colorful and I really like the colors, but it's also because it's stratified by age. And so it's pretty easy to pick out the youth and young adults in here, the age group of 13 to 24, as well as 25 to 34 in red and yellow. I think this is a really nice way of starting our discussion of looking at missed opportunities because I think it's pretty clear to pick out a couple of the areas in which we're going to start talking about right off the bat. And so I think one of the biggest missed opportunities in thinking about the care continuum for HIV is thinking about those who actually know their HIV diagnosis as a missed opportunity. Because if you were thinking about the care continuum for 2019, only about 61% of those who had HIV in 2019 knew their HIV diagnosis. And so there was clearly a missed opportunity for us to, in some way, of diagnosing those with HIV. There was about 40% who didn't actually know their HIV diagnosis at that time. So if we looked at that as one of our major categories of missed opportunities, we'll talk through how we're addressing that, or where our more finite opportunities were missed. And then as one other category I'm going to talk about is our sort of retention and suppression of viral load, but sort of thinking about it as appointment and medication adherence. So thinking of them more broadly as maybe diagnosis and prevention, and then adherence as our two sort of main categories of missed opportunities here. So why is this important? I think that thinking about this as sort of, we know that there are two main categories, but why is it important is really also something we need to think about. And I think it's clear that it's important because, and this is from 2016, but it still holds up in that we know that those who are unaware of their status or who had not been in care are still responsible for, in some way, for the vast majority of new diagnoses each year. According to the CDC, back in 2016, at least, about 80% of new HIV diagnoses came from those who either were not aware of their diagnosis or who had not been retained in care in some way, either because they weren't adherent to their medications or were not virally suppressed or in care consistently. And so some other fast facts, 1 in 2 people have had HIV for about 3 years. About 1 in 4 have had it for over 7 years, which I think is even a larger number in Baltimore itself. About 1 in 5 are diagnosed with advanced stage HIV. And I think that those numbers are pretty significant when we think about those who are youth and young adults, because if you think about those who might have had HIV for the last 7 years, if you were diagnosed 7 years, if you had HIV for 7 years and you are a youth and young adult, or you're even just getting out of youth and your young adulthood, 7 years ago, you would have been a youth. So those who are diagnosed along that continuum at, then in their 25 frame, they may have been infected in their teens. And so there's a great number of people that were missing an opportunity to diagnose in their youth. Another really important fact that I think we miss is that only about 25% of those that are at the highest risk of HIV are actually currently on PrEP. And that number is even more skewed when we look at people who are in their teens and adolescents, as PrEP uptake is notably younger in younger populations, or less in younger populations. So we know that testing is important, but we're not quite, so why is it not there yet? Or why are we not getting there with prevention? So these are from about 2 years ago, these surveys. So from both the Youth Risk Behavior Surveillance Survey, as well as the National Survey on Young Adults and on HIV and AIDS from the Kaiser Foundation. They both found that about 90% of high school students had not been tested for HIV up until they were about 18. This was a little bit better for those who identified as MSM, with about 15% of high school students who identified as MSM reporting that they had been offered a test for HIV, but only about 63% of young adults, so those up to about 25 years old, had never even talked to their healthcare provider about HIV. And this is clearly a missed opportunity. The AAP recommends that every person up to age 18, so between 12 and 18, gets an HIV test. So there's some missed opportunities if 63% of young adults have said that they've never talked to their healthcare provider about HIV. Somehow we're missing opportunity to talk to our adolescents, or we're doing tests without talking to them about them. And then there are 13% of young adults who reported that they knew about PrEP. And there's got to be missed opportunities if there's only 13 who know about PrEP at this point. There are clearly some disparities amongst different, if we look at this amongst races and ethnicities, with some studies reporting that there are greater numbers of those who identify as Black or African American reporting that they have been offered testing as opposed to their white or Latino, Latinx colleagues or peers, with about 34% of Black or African American high school students reporting testing in some studies, compared to about 16% of whites and 25% of Latinx high school students. So I think another really important opportunity that we're missing is really revolves around our structural, the way that we structure pediatrics. Pediatrics in general really lends itself to a siloed structure of care. So, I'm a general pediatrician. I do not practice. I'll never practice hem/onc or GI, and I love primary care. But I think that the pediatrics really lends itself to this siloed practice of care, and where we practice primary care and we get very comfortable with one practice of care in that way. We have primary care models, we have STI clinic models, and ER and urgent care. And it's really easy to assume that the disparities in testing sometimes come from teens being really healthy and not having a contact with HIV with any providers. But I think that's sometimes a naive assumption. I'd argue that this practice, the siloed care model, is this greater specialization of practice leads to less of an overlap of services and less of that necessary screening. So many of studies have shown that that youth who have been diagnosed with HIV, more of them came in contact with at least one medical provider within the last 12 months, either being a primary care provider or an acute care provider, and were not offered an HIV test. In fact, the CDC found that about 70% of all people with HIV, and that's all ages, were within the healthcare realm of some sort, whether that's some sort of specialty or ER or ER urgent care, within the 12 months prior to their diagnosis and failed to be diagnosed. And I think it's partially this separation of care, this primary care versus specialty versus ER or urgent care, that lends itself for us to have these missed opportunities to screen and link people to the right preventative care and HIV medical care and testing that they need. It also lends us as providers to limiting ourselves in terms of knowledge of both tests and services. We would get really comfortable with our single lane. And as providers, we get really comfortable with what we want to know. As a specialist, it might be very easy to only know about, I'm going to pick on hematologists again, and know only about hematology oncology and not know about the necessary screening tests that might be recommended for age. But if you are an adolescent who has a specialty disorder, you may only go to your hematologist oncologist and see them as a primary care provider, and may miss an opportunity to get a necessary screening test as you get older. And if you're somebody who has a certain type of risk, it may be more recommended for you to get screening tests more frequently. And so there's missed opportunities for us to do to provide those services. I think the other missed opportunity that we're missing is, once again, in that the one and done type of screen. Even traditional models years ago suggested, the AAP suggests that adolescents need one test between 12 and 18, but that they need it that we should start thinking about it based off of risk factors as well. And so more models like the status neutral approach by New York State or New York City have popped up, where an HIV test becomes sort of a gateway into the care system. And regardless of what the outcome of the test is, whether it be positive or negative, it's sort of a gateway into into a care system for PrEP discussions or for antiretroviral discussions. And I think that this is a model that more and more places are adopting, but it should be a way that we adopt regardless of whether or not we're HIV care providers, and we should be seeing this as a linkage to care for every type of care. And we should be seeing, and it is a possibility, and I'll talk about this a little bit later in how we can adapt this into a more comprehensive care model for any clinic. So shifting a little bit away from the prevention, I think that we also, we're going to talk a little bit about our missed opportunities in adherence. And the opportunities the missed opportunities that result in decreased in retention to care, and those that result in a decrease in the viral load suppression. This slide is a credit to Vicki Tepper. She gave me this definition. I think I like this one. It's got a underlined and bolded a couple of areas because I think they're really important. But I like the idea that adherence is the extent to which a client's behavior matches a prescribed healthcare regimen determined through shared decision-making between a client and a healthcare provider, and that it is an active participation in one's healthcare process. I think it's a really important part of this, particularly as I talk through parts later, because it's really important that it is a shared decision-making process. Nothing can happen, particularly with adolescents, without that shared decision-making, because you're creating a priority and a list of priorities that's based off of what is important to the teen or adolescent, but also what is possible, what they're capable of, and what is important to them at that moment. And adherence is also active. It is based off of what they want to do and whether or not they're capable of doing it right then. And it is separate from compliance, and that compliance is based off of a dictated regimen that is given to them from the healthcare team. And adherence is sort of an active participation on the part of the patient. There's a ton of things that I think impact adherence. And I think that this starts with really the frame of mind and the time frame in which we're looking at the adolescent. Adherence is impacted by internal and external factors, but it's also impacted by the ongoing developing brain of the adolescent. Adolescence is a time where the teen is sort of taking responsibility for their own healthcare. They're taking responsibility for their own the responsibility within their own decision-making for their lives. Sometimes they're moving out of their house. They're taking on jobs. They're taking on education responsibilities. But we have to also remember that the adolescent brain is still in development. Studies are showing that the prefrontal cortex, that area that is responsible for forward planning and judgment, is ongoing in development up and through mid-20s. And importantly, subcortical areas like the limbic system that's responsible for the reward develops far earlier. And so there's a really big imbalance between in the adolescence between that reward system and the judgment center. And so there's significant issues in risk-taking, the sense of invincibility, and that rational or irrational thought process. And while this high plasticity in the brain can expose it to environmental influences that can be really great and allow it for good external influences, it can also expose it to external influences that can have a negative impact on it as well. So let's think about some of those internal and external factors that might influence adherence. The biggest ones I think we have to think about are the physical and mental health competition or competing factors. So clearly, if there are competing health priorities, those might take precedence. Those might, especially if they're acute issues, they might take precedence. Concerns for side effects for the medications, depression. Clearly, depression might override everything else in someone's life, or substance abuse. I think one of the biggest things, as for us personally in our clinic, as we're looking at at internal factors, is that an understanding of HIV, particularly when we're thinking about our perinatal population and the age at which the disclosure of their HIV happened. More and more, we're sort of coming to an understanding that if their age of diagnosis, their age of disclosure happened at a younger time, they may have not had an updated understanding of their HIV. We may be building upon a knowledge base that's assumed. And so if there's not been an update yearly or even every visit or any time between now and 10, 11, 9, whenever their disclosure occurred, we may be working off of an antiquated understanding of what HIV is. And an assumptions are being made each time that we talk to them that they really understand what we're talking about their HIV. And they may not be able to really know what we're talking about when we're talking about the need to take their medications. And we're making a lot of assumptions about the way that they are interacting with us and that they can really take part in their healthcare in a meaningful way. External factors include parental or caregiver influence in the same way that peers influence them. And more as adolescents go on, peer influence takes precedence. Peer as peers become the meaningful group in adolescent's life, they take precedence over the parental care group. But at the early part, parental care or caregiver influence may be really impactful, particularly if they are the ones who influence everything about how HIV is discussed, cultural beliefs around HIV, or the belief around whether or not medications are important, or going to the doctor is important, or whether it takes precedence over other things in life, might make or break how a youth will influence or interact with the healthcare team. And then peer disclosure is especially important when we're considering the appointment frequency or medication timing, and influences how we're going to be able to interact with the adolescent moving forward as well. So sort of looking at external factors from the adolescent as well, but more based off of our system, our system factors, external to them and external to their lives. So these are not only limited to adolescents, but I do think that they can be tinged more towards adolescents in a way and may impact adolescents sometimes more vitally. So medical mistrust clearly is an issue everywhere, but is pervasive in Baltimore. It stems from actual events of experimentation and exploitation of Black bodies. It is worsened through racial injustice by police and racist remarks. And the healthcare system is often viewed as just another aspect of that system. For youth and young adults, particularly those with experience in the juvenile justice system or in the DSS system, this can be particularly worsened or tinged in a more meaningful way. And so if they're then they're then expected to navigate the healthcare system alone or in a difficult way, then they're going to have a much more difficult time trying to navigate healthcare on their own, or trying to trust any provider. Access to appointments may be limited. It may be limited either by transportation, by timing, by knowledge, and just by their own ability to navigate the barriers of calling a simple appointment. One of the things that we notice as we're sort of discussing the idea of transition with our adolescents is that many of them don't even know how to even make a phone call because their parents have been doing it for so long. And so the idea of creating a transition program where we teach our adolescents how to make those phone calls becomes an especially important idea as we're thinking about how limited some of our adolescents are in just navigating these medical systems. Cultural and linguistic barriers, not only just that language itself, but the cultural barriers of what is important to you. And that's sort of becomes really important as we're creating that adherence plan. What is important as we're creating to you as a person, to that adolescent, in making sure that we're addressing that as key to the plan. And then, I talked about it a little bit. I'm not going to go through each one of these, but I talked about it a little bit, but that provider knowledge is particularly important. And when we silo our care, knowing that a provider is not knowledgeable really decreases the adolescent's faith in the system that they're working, regardless of where they're seeking care. And so if they're asking a question of a provider and they either give them information that's not truthful or try to shirk that responsibility, adolescents are able to see right through that, and then they sort of veer away from any other providers in a lot of ways. So going towards the meat of this and trying to talk through really some strategies to enhance engagement, I want to focus more now towards what we can do and what's possible to sort of combat those issues that adolescents face. I think the biggest ones are on this page. I want to focus a little bit on here. I think the biggest thing to me is that while we will never as a whole in pediatrics get away from specialized services, again, I'm not a cardiologist or a hematologist oncologist. I think the biggest thing that I've seen it for HIV care is that it is possible to create a comprehensive medical home with primary care, sexual health care, and HIV medical treatment and prevention. I'm a general pediatrician, and I do the HIV medical care, and I think it is totally possible, responsible, and appropriate for that to live all together. You know, I happened to be talking with one of our residents from our program yesterday, and while they were with me for their adolescent rotation, and they remarked about that they had just picked up a patient in our resident continuity clinic who had just recently been diagnosed with HIV out in the community at a testing site. And that they had been referred to another HIV clinic, and that this had created a split in the services that this adolescent had, and that they were going to one place for primary care, another place for HIV medical care. They had another therapist, and actually had another location that they were going to for specialty services. And that while, you know, this more and more we're seeing some type of this model depending on your insurance that you have and where you initially start your services. And some people enjoy that, especially because of the stigma that sometimes HIV has. Youth don't always want that. They want to sometimes be able to decrease the stigma of going to a HIV provider by being able to just go to a primary care provider. And a lot of what our adolescents enjoy about our clinic is that they can come just to their primary care provider and just come to get their care all in one place. And so, you know, it had, for this particular adolescent that my resident was talking about, it actually was particularly stressful every time that she mentioned that her patient just talked to her only about the stress that going to her HIV provider had, because it entailed taking more time out of school to go to another doctor that they didn't feel like they had a relationship with, other than that it was their HIV provider that was the only person that they knew that could treat them. And so they didn't know really that there were any other options. And I think that this is something, you know, PrEP and NPEP are clearly something that primary care providers can do, but I think that this is another thing that we need to shift towards pediatrics to primary care provision, is being able to do HIV treatment or coupling them in the same location in the same way that our clinic does. Another really important thing is just making sure that your clinic and all the staff there are youth friendly. So making sure that cultural humility is addressed regularly. Our clinic does this through regular trainings. We do a round robin sort of method by training each other, going through different, at our weekly clinic meetings, each person does a different training on a topic to make sure that we're addressing topics that are interesting to us, but also address topics that are important to our adolescents. And then the thing that I think is most important for adolescents is accessibility. And so I'll just spend some time focused here, but making sure that it's accessible in terms of both the location, timing, and affordability, whether they're able to use their insurance, they're outside of their parents' insurance, or if they can use a sliding scale fee or a Title X service. So increasing accessibility can be done in a lot of different ways. So I'll talk about a couple different ways that we've tried to do this through our clinic and through the adolescent health program through Star Trek. And so one of the biggest things that I think really lends itself to accessibility is walk-in services. As I talked about, adolescents, the brain development is away from forward planning and towards that immediate reward, the seeking of immediate rewards. And so they don't always have the opportunities to wait and to call ahead for a scheduled appointment. And so having a walk-in service and an ability for immediate gratification really lends itself to allowing you to have better connections to care. Opportunities to do testing right on site and then link them to care later on, and even establish care on ongoing continuity of care can be a really big benefit for adolescents. Having late night hours or weekend hours, because youth and young adults may have traditional jobs, may have 9-to-5s that don't allow for a lot of paid time off, and they may not want to take their one paid day off to come and see their provider. And so having non-traditional hours and having a late night session or a round robin opportunity for providers to change their late night sessions, or a one weekend session a month can create that opportunity for more engagement or more retention for those adolescents who are leaving the house and trying to start their lives. Leveraging technology, I think, is another really important opportunity to meet adolescents where they are. So either using telemedicine, which I think we're all really hoping will stay around even after the pandemic, connecting to adolescents through the My Portfolio or My Chart app, and using that to discuss their lab results and providing greater education around what a CD4 count is and an HIV viral load is, and how they can impact that with their medications, and how they can request refills with the My Chart app. We may not be able to always reach adolescents by phone immediately, whether it's their job or their sleep schedule or their life, but the EMR messenger is a way, or texting is a great opportunity for engagement on a asynchronous way. And so our clinic utilizes, we all have work phones that allow us to text with our adolescents. It's been a really great opportunity for us to be able to answer questions or contact our patients on an increased basis. And I've anecdotally found that some of the patients who change their phone numbers more frequently, the EMR app will allow them to stay in contact with us a little bit more consistently that way. Pictured here is our Star Trek mobile unit. I am not the expert on this one. I think that this is a big benefit that I'm just going to credit to Vicki Tepper and to Jasmine Pope, because this was their brainchild. But I think that this is another, mobile units are an amazing opportunity for us to engage with adolescents out in the community where they are. So this is just a really pretty mobile unit, but I think that the really big benefit of mobile units is that it is able to go into a pop-up in a convenient and a convenient location, and take services where adolescents are and where they need them to be, and offer, as opposed to just pop-up tents, offer a private location for testing and services. And so one of our ultimate hopes is to be able to also offer our Title X services, our STI treatment services out in the community, and perhaps even be able to do follow-up HIV services. So taking our actual testing out there and follow-up services out in the community when we can't find our people, or if they can't come to us every time. And so I think that this is an opportunity to take your clinic to the people and really expand your services and expand your footprint. Home testing is another really great opportunity for that. And so again, this is Star Trek's, this is all the credit goes to them. This is available on the StarTrekHealth.org website. This is called That Box. And so this is an opportunity, another great opportunity to really expand the footprint of an organization and really get into the home of adolescents who need it. And so this, again, no credit to our clinic. Really, this is a credit to the Star Trek Health organization. They really do a really amazing job of expanding the footprint of our group, and to allow us to really get more people into the clinic itself, though, when we can, by offering HIV testing in their home and offering STI testing when requested. You can get more and more people connected to care. I think the really important thing that they're able to do is to do this in a status neutral way too. So when people do reach out and request a test, they offer them connection to service regardless of the outcome, though. So whether or not they're positive and they're connected to care, or if they're negative, they're requesting a service for some reason. They believe that they need a test. They believe that they need an HIV test, or they believe that they need an STI test. And so it's important to discuss what they believe their risk factors are and how to create a less risky situation for them, whether that's through condom use or through the use of PrEP or NPAP, and decreasing their overall risk factors to mitigate those risks in the future. So some other strategies, really looking at your teams and ensuring that you have an interdisciplinary team outside of just your traditional case managers and providers, but your nurse educators, and utilizing peer navigators. So peer navigation is based off of the model working with patients with cancer, but it's shown a significant improvement in overall quality of engagement for people living with HIV. I think that this is a model that really works well for adolescents because they are able to see themselves in the team that they're working with. whether it's that they can see somebody who's been successful navigating the system ahead of them, or it's that they can see somebody who they can rely on to answer any questions in language that they can understand. It's definitely a model that we lean on within the Star Trek outreach group. Addressing basic needs first is something that we have tried to do a lot as a clinic. So acknowledging and addressing unmet needs is extremely important, and setting those priorities first and setting them together. So Maslow's hierarchy is something that everybody should be aware or know. You can't really meet any needs without first addressing those physiologic needs. So things like food, safe shelter, food, and water are always going to come first, and it's impossible to really think about your healthcare, about taking a pill every day if you don't have a roof over your head. So we've seen a tremendous amount of success with our clinic by using a system of intensive case management to be able to address these needs in a unique way. Traditional Ryan White does not allow us to always address all of these needs. And so we're actually, as introduced yesterday by Jason Farley, we're one of the sites for this Getting to Zero Plus program. It's a partnership between Baltimore City Health Department and the REACH initiative at Johns Hopkins. And so we have 2 intensive case managers or Getting to Zero navigators in our program. And they each have a small panel of patients. We have just 23 of our adolescents currently enrolled in this, with 1 or 2 that sort of go on and off the program at any given time. And of those 23, more than 13 have achieved viral suppression, with several of them having achieved a sustained viral suppression of over 6 months. I think this is to me, this is like one of the biggest successes that we've achieved as a group. And I think, I think I'm really proud of this part of it because I think I can't take all the credit. This is really a credit to our case managers. But I think that this is really exciting because some of these patients have never achieved viral suppression in their entire adult lives. We have some that were diagnosed with HIV as adults, but we have some that are perinatally infected, and no matter whether or not they were perinatally infected and took over care from themselves as teenagers, or they were diagnosed as adults, some of them have never achieved this level of success, and being able to get them there, I think, was a really big success for our program. And it's because we were able to identify those unmet needs and really get to them first. Some of the things that we were able to do for them were as simple as, calling them every day. It's not really simple, but it's something that is not really like meeting an unmet need, but it's, calling or sending a text every day for an appointment, a reminder, or a medication reminder. But there were also things like providing toiletries and, giving them shampoo or towels or soap, or, giving them prescription refill calendars or pill boxes. But there was also things like giving them food gift cards or transportation to and from their appointments. One of our patients became pregnant during the program, and we were able to give her all of her baby supplies and transport her to and from all of her mother baby, or all of her OB appointments, and ensure that she had. We were able to basically set up her apartment before she delivered, and then we were able to take care of her after she delivered, and she's been on the road to success since then. We've also done things like, been able to help them with resume support and financial planning support, and it's all really based off of this program. And things like that stick with the adolescent and allow them to really not only find success, but also develop a rapport with our clinic, and then come back to us when they need additional support later on. Other things that I think are really important is to ensure confidentiality. There are a lot of studies that have shown that adolescents will forego all services if they don't believe that there is confidentiality maintained. Many teens have reported across many different studies that they are more likely to be honest if they are given multiple assurances of confidentiality. And confidentiality has been reported as the most important aspect on sexual health services beyond staff friendliness, location, and hours. There was a JAMA article in the early 2000s that said that 59% of the 550 polled adolescents would stop using all services if confidentiality was breached, but only 1% would stop having sex. So, we can't stop adolescents from having sex, but we can clearly, breach their trust and stop them from using our services. So it's pretty simple to just to really ensure their trust by talking about confidentiality, and also ensuring that we talk about the extent of confidentiality. So for our younger adolescents, one of the things that I always talk with our residents about is making sure that they talk clearly about the bounds of confidentiality. What is the extent to which their confidentiality can be kept, so that the adolescents really know that what is allowed, and it gives them a clear bounds of how far that they can go and gives them a good comfort zone. And then, I talked about being youth friendly, but being ensuring their comfort through sort of adolescent focused materials and creating a sex positive environment also goes into there. And then making sure that you use non-fear based language and, sort of refocusing their language back at them. If they use certain anatomic terms, making sure that you're feeling comfortable with those terms back, or reframing the same terms back to them is really important in increasing their comfort. The University of Michigan has a program, the Adolescent Health Initiative, that will actually help you do an inventory of your clinic to gauge its adolescent friendliness, its adolescent centeredness. And so you can get a level, a gold, silver, or bronze level based off of how adolescent friendly you are, based off of 12 different factors that range from your staff to the hours that you keep, the accessibility that you have, how much you talk about confidentiality, the posters that you have. These are just a couple of examples of posters that we have in our clinic that are from the AHI. But I think it's a really great opportunity for a lot of clinics to take a look at the policies that they have, the types of promotional material that they have on their walls, the types of inclusivity that they talk about, and the trainings that they develop for their staff to ensure that they do have something like this, and that they take a sort of an ongoing review of their clinic to ensure that it meets adolescent friendliness. And then the last section that I'm just going to look at or talk about real quick is making sure that as you're developing strategies with your adolescents or with your youth, that it's strength-based. So every adolescent is different, making sure to come at them each differently and adjusting workflows to meet their needs. So every time we talk with a different client in our clinic, we are adjusting our workflow for them. Sometimes they need to see me or the nurse practitioner for a few minutes. Sometimes it needs to be the whole visit. Sometimes they don't need to see me, but for a minute, and then they need to see our social worker or our nurse for an hour. And we really need to make our workflow meet their need, or we need to get in and out because they need to be there for 5 minutes and they need to get their labs because we need to prioritize getting them back in the door sooner. And I think part of that is meets the qualifications of this approach. We need to really know that their time is a priority, but also that sometimes we just need to get in and out of the room. We also need to, as we're developing our approach and discussing how we're going to meet the adherence goals, we need to sort of identify the strengths and supports and barriers for them and each one of these, because they all play into how we're best going to care for them and how they're going to develop their goals of care. And understand that they're going to fail and they're going to succeed and they're going to pass back and forth between those different phases of the HIV continuum. They're going to be retained in care and they're going to have viral suppression, and then they're going to fall out of care, and we're going to need to meet them back where they're at every single time and be happy for them and be happy to see them and really constantly be there. And I think that that's a really important aspect of working with adolescents. The continuity of care thing I think is also really important. And in our clinic, we have 2 transition programs that are equally important for us. We have our STEP program that's run by Dr. Riskavich from the Thrive program. This is our program that helps us with the transition of adolescents to our adult program. Dr. Riskavich comes into our adolescent clinic and meets with adolescents for anywhere from 2 to 6 times. And a sort of transition program is developed between him and a case manager to really assess the readiness of the adolescent in their pathway to transitioning to the Thrive program. And so, as they are sort of ready to transition, a warm handoff is done between the case managers at our AAC and then the Thrive program to ensure that they are well transitioned in case management as well. And then they're sort of co-managed for the first couple visits until they're clearly transitioned over and we can sort of sign off on their case. The other program that I think is I love and is Sandra Dean, our case manager down here. Really it's her program is our SPICE program, and about 50 mother baby dyads a year come through this program, and they're followed from through OB, through our program, and then to their community pediatrician in terms of the babies, and then from OB back into their either Thrive or their the mother's adult HIV provider. But there are about 50 different dyads a year. And so Sandra will follow, this is really a case management driven program, and Sandra will really follow the mom from their first OB appointment all the way through delivery. And then we'll follow them together for about 6 months after delivery as we confirm the infant is HIV negative. And then as we transition them to a community pediatrician, Sandra also ensures that every mom is connected back from their OB to their HIV provider. And about 20 new moms are diagnosed a year. And Sandra ensures that each one of them has a HIV provider. So often we'll go to their first appointment with them, connecting them with each one of them with an HIV provider she trusts, that sometimes that she trusts implicitly, that she trusts that she's gone to with other moms in the past. And she'll go to their first appointment, their second appointment. She takes medications to them at their homes or at the bedside each time. And she makes sure that to follow up with them on a regular basis. And so that she develops a really close bond with each one of them. And each one of our seronegative fathers is tested as part of this program as well to make sure that we are and connect them with either PrEP or with a primary care provider to discuss that as well. And if they need to, they connect to our clinic if they're within our age range as well. So I talked longer than I thought, but I'll do my quick take-home points. But engaging youth is often more about identifying the missed opportunities. It's both structural and logistical. Youth face both internal and external factors. They are both systemic issues and developmental. And there's no single strategy that is going to overcome all barriers. They are going to be multifactorial, and I think that it really depends on the youth. And just like we have to meet each youth where they are, we have to sort of develop a strategy for each individual factor to sort of combat it as well.
That was great. Absolutely fantastic. And I'm smiling because when we asked you to do it, you're like, oh, but I'm not the expert. You are quite the expert. I really love how you interwove all the pieces, the 360 piece, CIS, medical mistrust among youth, shared decision making, all the things, practical tools and tips for people, even how to evaluate their own programs. Really great job. So before I start talking, I'd love to open it up for questions or how-to for Matt, input guidance, really open it up to everybody before I jump in. See a lot of familiar faces on the, yeah, you can please feel free to put your camera on, unmute yourself. Keith Holt, go ahead.
Well, first I want to say thank you so much for the presentation. It was great. Thank you. So it's so good to see that such positive work is going on to really, basically disseminate this information to the community. I've been a long time community advocate in Baltimore, and I've always said that every day is kind of like a pyramid effect, you know, or it's kind of like an iceberg, kind of like when we think about the Titanic was sailing on the water, living life all fine and dandy, and then it got hit by the iceberg. But, you know, we don't really talk about what was underneath the iceberg. And I'm really happy that you really addressed those things that, you know, even with HIV testing, we always say, get tested, use a condom. Those are the things that's at the tip of the iceberg. But it could be so many underlying reasons why a person may not be able to use a condom. It could be that they're in a relationship with a person and they have survival sets and they have to have sex with this person in order for a place to live and things like that. We don't consider those things. So I'm extremely happy, and I'm excited that I came on to see that those things are being considered when we do think about how to reach communities, because at the end of the day, no one is hard to reach. We just have to go to the places that they are to reach them. So thank you so much for this presentation. And that's all.
Thank you so much for saying that too. I didn't explicitly say that, but you made a really good point in that we don't always consider all of the extra ramifications or conditions in which some of our adolescents are living, and that the things that they have to do to sort of survive. And you know, survival sex is an excellent example of that. And it's another barrier that we have to really put our adolescents in the terms of like that sometimes they can't get testing or they don't feel comfortable getting testing. And it's not as simple as just saying get tested, or the frequency of testing may not be appropriate for everybody. And, you know, but that's a really excellent point in that there are additional barriers we have to also think about there too.
Definitely. There's a quick comment in the chat about highlighting the reasons that particularly Black patients may mistrust the medical system, and just highlighting that and being a really critical piece of putting it together. I think Caitlin Rieger, you had your mic off. Go ahead.
Yeah, I have a question. First, thanks so much for a wonderful presentation. I know something we've seen lately with our patients is some discordance and tensions between the information that the provider is giving and how the parent feels. And I'm wondering how you navigate kind of those parental tensions and influences as the adolescent gets older, and like at what point can you tease apart an adolescent visit from their parent as they're kind of learning more and developing their own ideas and thoughts about diagnoses?
Oh, that's a really good question. Are you sort of referring to like when like an adolescent, like an HIV positive adolescent and their parents, and having that discussion, like what the parents' feelings are towards the HIV at that time, or just in general, like any sort of discussion with the parent in the room?
A little bit of both, but primarily like I'm thinking of examples of when parents come in with like cultural barriers or other potentially like intellectual barriers or things like that keep them from understanding the diagnosis in a more like in a accurate way, and like, so how do you work with the adolescent to understand their diagnosis without damaging the relationship with the parent? Yeah,
I think that for one of the things that I think has been the most difficult thing for me personally is the time frame around as teens are taking on the ability to start taking on their own responsibility, and when, especially for HIV positive adolescents, when disclosure should occur, and getting parents on the board with disclosure, because it's a self-disclosure for a lot of parents as well. And when it's culturally very difficult for a lot of parents to feel like they can disclose, and having that group decision-making around that for the parent-teen dyad. But I think that there comes a point where you have to also recognize that which is your parent or which is your patient. And to me, the patient is always the adolescent, and my responsibility will always be to the adolescent. And I try to leave, and at the heart, if I keep my priority to them, I know that if if my goal will be to keep them in care or give them the best foundation to maintain care longitudinally, I have found that I can get trust to the parent by having a honest conversation around what my goal is. Like, every parent's goal is that they want their kid to be well, and they want the same thing for you. They may have a different route to get there, but having an honest conversation may be separate of what your goal is and why you want to have a conversation with them around something may be the way to do it.
Thanks so much. I appreciate it.
I think it's a really good point. I think I heard two things in your question, Caitlin. One, it's the tension between many of our adolescents are super savvy, sometimes even savvier than the parents, and trying to dance around that. But two, I think particularly at those ages of transition, there is that fear of losing control of, well, as the adolescent takes over, will they fail? Will they this? Will they what have you? And recognizing that at some point the adolescent becomes the primary, has always been, but really is the patient, and we have to move in that way. And some of the goals of the parents may not align with what the kids actually want and what maybe prioritize. A couple of other questions. Yeah. So yeah, a couple other questions in the chat. One by Ricky Moyd. Are the 91% of high school students identified as missed opportunities for testing, where they offered testing and not being tested, or were they not offered at all? And just asking for some insight on that. I think this is the YRBS data, right? Yeah,
it was the YRBS data. And I believe it was that they were not offered testing. I don't think it was that they declined it. I think it was that they were never offered the testing.
If it's YRBS, just that maybe contextualize that a little bit, it's the proportion of adolescents who report ever receiving an HIV test. And so 9% report receiving an HIV test overall, maybe a little bit higher in youth who identify as LGBTQ youth. So we may not know that piece, but we do know in talking to providers, there's a lot of reluctance to test, right? Because what am I going to do with it? What do I do? So I think it's probably a mixture of both that populates that. And then, yes, we will share the slides, definitely. Other questions and comments. I have one. I'll get mine in now since we don't. Wondering how you were able to, I think we're all practicing at different places with different rules, and how you were able to get your institution to open a after hours or evening clinic. What kinds of things were used to be part of the equation to convince?
So we've gone through different iterations of it. We actually opened it before the pandemic, closed it during the pandemic, opened it again briefly, and it's now during staffing times we've had unfortunately to close it during part right now. We staff it with, because we are isolated and we're a little bit smaller over here, we're able to staff it ourselves and just say that we'll do it, and they just allowed us to do it, which was kind of great. We basically said that, like, we're totally, our clinic is 100% grant funded. And so we told them that it would only increase what we can give them if they give us more, if they allow us to do these after hours, and it wouldn't take anything away from them.
What has been the response for the young people? Do you have an onslaught, or just curious how that?
When we opened it, we had, it was mixed. There was, I think that we had some mixed times. I think that we've always had more use of the walk-in hours than anything. I think that I would love to get more, when we have the opportunity to do late hours again, I want to try it. I'll be excited to try it again and vary the date to see if it's something along those lines. I've just always wondered if we just didn't have the right day, or if there was something that if we could advertise it differently, if that made a big difference. Because I think that especially our age group, we've had people say that they just want to come at a later time, and that it would make a big difference for them. And I just don't know if that's true, or if they're just saying it to make us feel better.
Matt, I realize we have 1 minute left. I think if I took anything away, and I took a lot of things away from your talk, which again was fantastic, what you're talking about is meeting young people where they are, acknowledging the cognitive developmental changes that happen, and creating opportunities for access, right? Optimizing, you want a weekend hour, we have that, we have this, we have that, we have everything to literally meet you where they are, recognizing that youth may change the next time you see them, and the next time and constantly reassessing and adjusting. there's one last question. Have you partnered with community members, leaders in the community to assist with disseminating information? And Keith, maybe you can add to that. Is that about the program, or curious what specific information you may be speaking to, so Matt can answer appropriately?
Sure. I was talking about basically the comment that he just said with the clinic and things like that, with getting information out there. I was just saying, has that been something that has been brought up to help disseminate the information about the clinic and any, just anything, any new initiatives?
Yeah, I think that that's probably something we'll need to do a better job of, is disseminating it a little bit more widely when we do.
This is part of why Matt is here, to engage and amplify. And now you all have heard, and now you spread. And I think what I love about the work that we've been doing with the University of Maryland as part of the JH Wiki is that we truly have very complementary programs and are leveraging what we each are doing to, again, improve the care for patients in our city and our region. Matt, that was fantastic. Again, thank you for sharing your expertise on what you are doing. And what everybody's doing over at Maryland. Really continue to look forward to working with you and your entire team. I want to remind everybody that next month we will have our youth forum, which promises to be exciting. They're going to have a fishbowl where they're going to talk about what they want, their needs, and how we as a community of providers can assist and meet them literally where they are, hearing it from the youth themselves. So really excited about that. With that, you're going to get an evaluation after this. We do please want you to fill that out, give us your feedback. And then again, if you have something you would like to share, we'd love to have you also be featured as our local experts. With that, we'll close, offer you the rest of the 1 minute to enjoy the rest of your day. And we hope to see you next month. Thanks, everybody. Thanks again, Matt.